In terms of very specific guidelines on what to do when a patient is in a treatment-free remission and relapses. So the first important thing is, as I said, they're being monitored with an assay that has a level of sensitivity down to MR 4.5. For those of you who don't talk log anymore, we haven't said it yet, that's a BCR able to able ratio of 0.0032% or lower. And what the patient should have done is, I said how often they're monitored. If they lose an MMR, at any point, one determination, you start them right back on nilotinib at their prior dose, and you monitor them closely. And if they're not achieving an MMR, again, within, I would say within 3 months, definitely do mutational analysis. If they're in second-line nilotinib or an able TKI, maybe being a little bit more careful, and if they lose an MR 4.0 to determination confirmed, you should start them back on an able TKI, and again, monitor them very, very closely. But as long as a patient remains in an MMR, you can continue them in a treatment-free remission, because that's the level at which we feel people are prevented from progressing to blast crisis. Mike, do you want to talk then about what are the unmet challenges and needs in treating CML and maybe this issue?
I think you just hit one, which is the retreatment success, or prompt retreatment with the same TKIs tends to work, which is a real boon, because I think many people were concerned that we would have to change things up in the advent of a failed TFR. But probably the biggest issue is that across all these studies, it's 50-50 shot, basically. We'd love to say it's 70, 80, 90%. So with the increased prevalence of CML we talked about a while ago, and this journey, the fact that this is our goal, but still 50% of people miss, what can we do to try again? Now, there's some data out there just simply restarting the TKI, waiting an appropriate amount of time. Maybe we were just a bit premature. I think there's mixed feelings on whether that's how successful it is. It's probably lower, of course, than the first trial. It may be quite a bit lower, maybe just a bit lower. But I think there's a lot of ideas out there. What's going on? Maybe we need to change the quality of the remission. Most ideas are thinking about adding something to the backbone of that stable patient, again, who's back on their TKI, probably back in deep remission, to deepen it a bit more, hit another pathway. Examples include ruxolitinib, maybe ABL001 can be incorporated into this picture, I think, with the promise of that drug, and a number of other ideas. So second TFR is probably the next horizon, I think, because it's, we gotta help that unmet 50% who can't hit it the first time.
Yeah, and in fact, in both the Ines Freedom and Ines Stop study, during that consolidation phase, as I mentioned, some patients were not eligible for TFR, and so had to continue on. But when they were still followed, and later on, when they achieved those things, they then stopped the nilotinib in that study. And it was a very small number, but it was a similar number who were able to maintain that treatment-free remission and not lose a major molecular response. Well, this has been a great discussion. Before we conclude, I'd like to ask each of our panelists to provide a takeaway from this program. So I'm going to start with you, Jorge.
My takeaway is going to be about TFR, because I think it is something that's become very real. I think we never thought we would be at this point, and some of us may have been actually skeptical even when we started hearing about these points, but it is real. It is here, and I think we need to help our patients get to that point. We talked about the fact of the education to the patients from the beginning, their responsibilities, but our responsibilities as well to try to optimize the chances of the patient getting to that point. And one thing that I want to emphasize, we frequently talk about, well, that's the clinical trials, but what about the real world? This is the real world. I mean, the two studies that you described, the Ines Freedom and the Ines Stop, these patients started on treatment before they got into those studies. They were already on treatment. They were part of the real world. The key difference here is that when they got to the trial, they were monitored very closely and they were managed very properly. So I think this can be done. It can be done safely, but we have to manage them as if they were in clinical trials, which is essentially what the NCCN guidelines and the ELN guidelines tell you. Do it this way. Now, if we're not going to do it, sure, we're going to lose some responses, we're going to miss them, and then we're going to say, oh, no, they do transform to blast phase and whatever. Well, yeah, if we're not looking, that's going to happen. So this is the real world. These studies have been done in the real world. There have been, many of them have been observational We just need to make sure that we do it safe for our patients. We don't want to transform something that was very, very good, a good response, into a very bad situation for a patient because we're not doing our job.
Yeah, I agree with you. I think this TFR data, all of these multiple studies, the length of follow-up we have, sure, it's not decades, but it's long enough for us to say, I think it's reasonable under certain conditions, close monitoring, to attempt this after you discuss it with patients. And they may consider it because of conception issues, short-term, low-grade toxicities, the concern of long-grade toxicities, financial issues, which, by the way, that would be my point about TFR. And you mentioned this earlier at the beginning, the prevalence of this disease is going up. And of course, we've all know that imatinib is generic, and someday that will translate into a lower cost for society and maybe even our patients. But if you think at a global level, and I am not a healthcare economist, but maybe we should start thinking about starting with second-generation drugs, not just because of preventing progression, not just because of those early MMRs, but really because of getting patients to a point where they may attempt a treatment-free remission. And if we could get patients off of these drugs with the prevalence of the disease going up, would that be more of a cost savings for the entire population than thinking about which able TKI we can get the best deal for? Mike?
I'll take Jorge's ball downfield a little bit and say that we have to pay attention to how we treat our patients. This is such a good story, such good success, that missing small things, not having the monitoring trail off a little bit, not really being engaged with adherence, the cardiovascular risk stratification, these are not hard things to do, and it probably can make a real difference for patients. So as a community, we owe ourselves to watch programs like ours, like this here, work with our sponsors that can sometimes help get molecular assays, can really provide good educational materials. Just make sure we do the best for our patients, because it fortunately is a very good story and a disease we can treat really well. We just have to be meticulous.
I agree. Well, thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.